we have a talk now on can early diagnosis improve outcomes in MASLD? And to deliver this talk, I invite Dr. Sandeep Satsangi.
Good evening. Thanks, organizers, for the kind invite. I think a very important question, a very pinpoint question given to me as my talk, can early diagnosis improve outcomes? Okay, so when I actually thought about this topic, the most important points which came up as a hepatologist was, can early diagnosis in MASLD spectrum pick up more patients in MASH? Can early diagnosis of MASH and metabolic syndrome impact patient outcomes? And do we have better therapeutics for MASH if diagnosis is early? These are the most important questions probably will come to our mind. So very brief introduction, we know that the prevalence is high in India. The studies show as much as 50–55%. And the risk of MASH increases with increasing age, male sex, and if you have multiple comorbid metabolic risk factors. Very important data I'm sure most of you would have seen. A seminal paper which showed that people who had fatty liver were living less when compared to general population. And the main risk was not liver related, it was predominantly malignancies, cardiovascular outcomes, and then liver related risk factors. But a subsequent study actually showed that when a sub-analysis was done, it was mainly the NASH phenotype which had the poor outcome and not the people with plain fatty liver. So the question actually came up that is fatty liver really benign, a plain NAFL? I think there are some more data which I'll be showing across. But do we have a severe rapid progression from NAFL to NASH? I think this is what we should answer because that is where the early intervention would come into picture. So this was a study of around 50 patients, paired biopsies over 3 years. And what do we see over here? 38% of patients progressed from plain NAFL to borderline NASH and around quarter of them to full-blown NASH. And a very important point also was driven from the study, that if you have waist circumference coming down, BMI control, that is an independent predictor that this patient will not progress. So again, early diagnosis, it's not only early treatment, but probably just lifestyle intervention does miracle in these patients. Next, systemic review for 70 patients, again with paired biopsies. What did it show? Around 64% patients of plain NAFL going into NASH over a period of 3.5 to 4 years. Quarter of them landing up with bridging fibrosis, just over 3.5 years, quite significant. 108 patients over a follow-up period of 8 years. What does it show? Around 44% patients landed up with NASH, a third of them with progressive fibrosis. But an important point over here, we do know that plain NAFL has two subtypes, one with bland steatosis, one with bland steatosis and mild inflammation. Only if you have ballooning would you call it as NASH. So this study actually said that even those people with some steatosis and inflammation not going on to NASH also have chances of fibrosis progression. So even that phenotype is important. Patients with NASH were found to be older, obviously because they are suffering more with metabolic risk factors, including diabetes. And an important point was type 2 diabetes mellitus was the significant factor in those patients who had progressive fibrosis. Again, hinting us that it is not MASLD only you're treating a patient who's obese, who's metabolically ill, who probably has uncontrolled diabetes, and when you treat these things, you're actually preventing these patients from marching on into progressive fibrosis. Very important study by Dr. Rohit Lumba's group. What did it show? It basically showed, again, out of around 400 patients, 33, a third of them went into progressive fibrosis. But an important point was, there's a subset of patients, approximately 20%, who are rapid progressors. So these patients, over just few years, 3 to 5 years, from F0 would go to F3, F4. And that is the problem. So rapid progressors. So this is the dynamicity of NAFLD. And a very important article by Arka and Dr. Duseja on this. So you can oversee, this is the initial part would be the plain NAFL, and if you have the ballooning, it's called as NASH. And from basically these two parts, you can have 20% who can be rapid progressors going into progressive fibrosis, and 80% would be those patients who progress very, very slow, but you're basically interested in the phenotype which are rapid progressors. So the first point the question which we had. Can early diagnosis in the mast cell spectrum pick more patients in NASH? I think the question itself is wrong. Single snapshot at the time of diagnosis is less clinically relevant. I think that we made a point on that because it can rapidly go on to NASH. So just one time, if you even do a biopsy, pick up NAFL, no, not very important. Patients with progressive fibrosis need to be picked up. Reduction in waist circumference, apt control of metabolic risk factors, and diabetes would probably definitely prevent disease progression. The second question, okay, can early diagnosis of MASH and MET syndrome improve or impact patient outcomes? Some data on that. So very important study by Professor Sanyal, around 1800 patients were taken. Clear data showing that all-cause mortality and liver-related mortality significantly went up as the fibrosis stages went up. Again, an important point that when compared to early fibrosis, people who had F3, F4 had higher chances of incident diabetes and also development of declining GFR, that is going into CKD. So more fibrosis, more chances of going into CKD. Very important point is that cardiac events and non-hepatic cancers happened all across the board. So whether you have mild fibrosis, advanced fibrosis, it is same. So cardiac events, non-hepatic cancers, be careful with that. Again, a study of around 230 subjects. What did this show? Very interesting point. Irrespective of the NASH, if you have early fibrosis, the all-cause mortality did not increase. So you see in the first group, NAS of 5 to 8, that is full-blown NASH, but the fibrosis was less, the mortality was not more. If you have NAS, irrespective of any NAS score, if you have F3, F4 fibrosis, the mortality goes up. So all these data clearly hint to a point that fibrosis is a very important histological marker of liver-related mortality. For cardiac and non-hepatic cancers, it is the mast cell, it is obviously the metabolic syndrome which is driving those entities. What about the data on heart? So a lot of data has come up that, and it's very common for us to see patients of MASLD coming with heart failure symptoms. Usually we know that NAFLD is associated with a lot of pro-inflammatory state. It's basically because of TNF-alpha, CRP levels, and that basically causes a lot of endothelial dysfunction, myocardial fibrosis, basically a diastolic dysfunction happening. And if you catch them early, just the weight reduction, lifestyle interventions, if you treat the diabetes, for example, with your DPP-4, your dapagliflozin, SGLT2 inhibitors, semaglutide, not only are you improving your MAFLD, but you're also improving their cardiometabolic risk factors. What about cancer? We all know that NAFLD, HCC can even happen in NAFLD without significant fibrosis, but it does say that the incidence is less. The incidence clearly goes up as the fibrosis goes up, and the incidence goes up if you have histological documented MASH, 10 times more incidence. We did discuss this in the previous slides that in contrast to HCC, the non-hepatic, extrahepatic cancers were completely same all across the stages of fibrosis, and the most common were uterine, breast, prostate, colorectal, and lung cancer. Imagine you're diagnosing a patient with metabolic dysfunction with diabetes. He has some cardiometabolic risk factors. You're putting the patient on metformin. So the data with metformin, the data with statins, aspirin, all show that if aptly used in that patient population can reduce your HCC risk. Aspirin to as much as 30% risk reduction. Very important data. Again, I found it very interesting. Again, it's a mice study, but I just thought it is interesting. So in this, what was basically done, that a group of mice were taken and HCC was triggered by injecting diethyl nitrosamine, and these mice were fed choline deficient high fat diet, basically triggering fatty liver and triggering HCC. One group of mice were given SARO, one group of mice was not given SARO. The group which was given SARO, none of them developed hepatic tumors, and the group which was not given SARO, all of them developed hepatic tumors. Again, indicating that maybe treating the MASH phenotype early would probably prevent your HCC development, but again, just a mice model study. So the second question, can early diagnosis of MASH and MET syndrome impact the patient outcomes? Better control of metabolic risk factors and diabetes can help prevent fibrosis progression, improve the cardiovascular outcomes, reduction in cancer risk, and initiation of therapeutic drugs early in the disease can probably help. But do we have therapeutic drugs which work better in the early stage? I'll not go into details over the next 2 slides, but we all know about resmetirom, got recent FDA approval, 30% NASH resolution, 25% fibrosis reduction. But again, all this is in F2, F3. Will it work in F4 fibrosis? The data is yet to be out, and this is a study which is ongoing. for resmetirom in compensated cirrhosis. We all know about the NEGM paper, 59% reduction in NASH, resolution of NASH. But again, when assessed in patients with F4 fibrosis, didn't work, semaglutide didn't work. We all know about the regenerate, did show good outcomes of OCA, but again, when it went to the reverse trial, didn't work. So once you hit F4, you're probably, there are very few drug options because the histological endpoints in F4 are really difficult to attain. Selonsertib was very promising, Stellar 3, Stellar 4, disappointing. Cenicriviroc, disappointing. And for SARO, I didn't find any much data. Very recent publication that they are incorporating pains of cirrhosis and it is safe. But whether it will cause fibrosis reversal in F4 with SARO, the data is not yet out. Last slide, basically you see that this is entirely crowded in the initial parts where in F0, F1, you are mainly focusing on metabolic risk factor control, F2, F3, you have data on resmetirom and good drugs in this stage. But once you go to F4, it is mainly cirrhosis-based management. So you have to catch it early and treat it early because of so many benefits. So concluding slide, early diagnosis of MASLD, primary emphasis should be on treating metabolic syndrome and lifestyle interventions. We saw good amount of data on that. Single snapshot diagnosis of NFL or NASH may not be very fruitful. It is mainly you have to focus on this metabolic syndrome control and identifying those subset of patients who are progressive fibrosis. Hepatic fibrosis is the key independent histological hallmark to indicate hepatic outcomes at least. Therapeutic drugs, both MASLD specific, you have good drugs now, but antifibrotics once you go into F4, not very, very effective. So I think we clearly made a point that early diagnosis in MASLD does improve patient outcomes. Thank you.
Can we have any comments or questions from the chairpersons?
Hello. So from here. So do you think AI will enable us, AI-enabled ultrasonography, fibroscan, or maybe histopathological analysis, will enable us to diagnose disease even at an earlier stage? Do you have any data to support that?
Yeah, I think probably I don't have data to support that, but again, I think it will create more homogeneity if you have, because right now, as probably pointed out in the previous slides, you have so many ways of finding out whether your patient is in NASH, but none of us do biopsies regularly. So you have so many non-invasive methods to figure out. Certain people of us would do fibroscan, some of us do MR elastographies. But I think whatever we do, I think the entire emphasis in the early part at least should be to treat metabolic risk factors, because it's not only the liver you're worried about the non-hepatic cancers which can even happen in early stage of fibrosis.
So I have a diode also. And there are various staging, for example, categorizing the patient with steatosis as well as fibrosis as well as for your metabolic associated steatohepatitis. For example, if you're planning to focus on FAST or if you're planning to focus on MAST, MRI based along with the AST and a fibroscan along with the AST, as well as the various markers are being there. Among this, corrected T1 also being nowadays based upon your MRI being tried, and along with your NAS2 scoring system also being tried. So what is your opinion? To categorize the patient as your metabolic associated steatohepatitis, so which one would be the best pointer to take into account? As per various guidelines, they've been taking most of the things into practice. What is your opinion in that?
Sir, I think my opinion in this would be try to pick up your patients much early in fibrosis. So F2, F3 is the early stage of fibrosis you want to not miss. Now again, as per the data, I think it's clear that MR elastography wins over fibroscan. Also because you see that fibroscan has a lot of variability in terms if you have an obese, you get a higher values, and if the machine is not calibrated, you get a wrong report. So MR elastography heads down is better, but again, comes at a higher cost. So whichever probably works, I think the future is towards non-invasive diagnosis of more fibrosis, because that is a key deterrent of your outcomes.
Okay, Sandeep, I think we'll have to, sorry sir, we'll have to end this session, end this talk right now. And we'll move on to our